Good afternoon, everyone, and welcome. My name is Amanda, and I'm DWDC's Program Coordinator. Today, I'm joined by my colleagues, Kat Bartons and Kelsey Goforth. Before we begin, I want to acknowledge that while we are meeting virtually, the land Dying with Dignity Canada is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Indigenous, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and we invite and encourage that you do your own research regarding the various treaties, in particular the land in which you're on, while meeting with us today. All right, so I am thrilled to welcome you today. Through our webinars, we aim to provide you with information and key takeaways, as well as create a space for conversation on end-of-life topics alongside the professionals that know it best. Before I welcome today's speakers, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit your questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you during the session. We ask that you please try to keep your questions as concise and clear as possible. And of course, while we are going to try to get to as many audience questions as possible for today's session, unfortunately, we may not get to everyone. If you have any outstanding questions or any questions that are personal in nature, please feel free to email us at support@dyingwithdignity.ca, and we will follow up with you. The session will be recorded, so there's no need to take notes if you don't want to. And also, there will be a post-webinar survey that will pop up on your screen after the webinar and will give the opportunity for you to share your most valuable feedback. Alrighty, and my favorite part here, last but not least, I'd like to take a moment to spotlight an upcoming special project that will be premiering on World Right to Die Day this November 2nd. In My Own Time is a documentary that looks at what it means to die on one's own terms. Using firsthand accounts from people across Canada, this film will offer perspectives on medical assistance in dying, less commonly seen in media reports, and present an opportunity to educate people on end-of-life choice in Canada. So on November 2nd at 7 p.m. Eastern, Dying with Dignity Canada will be hosting the premiere of In My Own Time at Scotiabank Theatre in downtown Toronto. So that's next week, Thursday, for those that are still interested. Other screenings will be taking place across Canada throughout the month of November, so please be sure to follow us on social media for future updates, and we hope that you can join us. Okay, and now to introduce our wonderful speakers. First up, we have Erica Maynard. Erica is a full-time nurse practitioner with extensive experience and leadership in the assisted dying space. She has served as a MAID assessor and provider for Nova Scotians since the inception of MAID in Canada in 2016, and has assumed many roles within the Canadian Association of MAID Assessors and Providers, known as CAMAP. In addition, she also serves in an advisory capacity on the Provincial Territorial Advisory Committee, as well as DWDC's own Clinicians Advisory Council. So thank you so much for joining us, Erica.
Thanks for having me.
Of course. And next up, we have Dr. Aaron McKim. Aaron is a MAID assessor and physician with expertise in emergency medicine, palliative care, and complex geriatric care. He's the medical director for medical assistance for Eastern Health and a member of the Ross Family Medicine Center's Faculty of Medicine. His current work includes helping to train assessors, manage complex cases, and help expand regional MAID programs in an integrated community network. Thank you so much, Aaron, for joining us.
Thank you.
All right, so thanks to our panel again, of course, for joining us today. Now, our format is a little bit different from what our audience may be used to. So today, we're going to be reading out questions we received from audience members just like yourself. Thank you so much to those who submitted through email, through a registration. We're most grateful for the enthusiasm and support. All right, so we're going to go ahead and get started with our first set of audience questions. And just a reminder, if you have any questions during the session, please feel free to submit them in the Q&A panel below. Okay, so I think for our first set of questions, let's start with an introduction. And Erica, maybe I'll start with you. I'd like to ask, how long have you served as a MAID provider? And I think we touched on that a little bit, but maybe why you chose to serve as one.
Yeah, so I actually started in the inception of MAID in 2016, but not all the time in Nova Scotia. I was actually on Vancouver Island for the first year and a half or so that I was doing MAID. After that, towards the end of 2017, I have been here full-time in Nova Scotia. So both doing assessments and provisions since that time. And then since January of 2021, I've actually been a full-time MAID assessor and provider. So this is the only thing that I do now. I finished my family practice and moved into MAID full-time. What really had me deciding to do MAID is that most of my career I had actually worked in the intensive care unit. And so I had seen a lot of suffering during that time, and perhaps suffering that maybe people couldn't perhaps tell me they didn't want to go through. During my time as a nurse practitioner in family practice, I saw many, many people get diagnosed with a metastatic palliative cancer, and again, suffering perhaps needlessly. And so when the opportunity was there to participate in MAID, I took full advantage of that in order to help people alleviate any end of life suffering that they necessarily did not choose to go through.
Absolutely. Thank you for sharing that. And same question to you, Aaron.
Yeah, I've been involved with MAID since, well, before the legislation changed. It was on our horizon. And at that time, I was the clinical chief in long-term care, which meant I also worked in long-term care. So I saw the front lines, and I saw that in some instances people were being forced to endure torment and suffering against their will, and they had no legal options. But I could also see it from the practitioner's side that a lot of the physicians who I was the chief for, given the population, there's probably going to be some asks for MAID assessments and provisions. And so I wanted to be ready so that any of the physicians and nurse practitioners who I worked with would be able to have some backup and would be able to have somebody who could help show them the ropes. And I had a fair idea of the, I guess, the behind the scenes infrastructure that needs to be in place for things like that to work properly. So I didn't really necessarily want to be the guy, but there was really nobody else in this neck of the woods who was in a position to be able to set things up, to devise protocols, to get forms set up, to network and with other parts of the country, find out what they were doing elsewhere. So it was more, I was kind of called upon by the situation. It didn't make sense for me that, we could provide a mercy to our pets, but we couldn't provide this mercy to our elders. It just didn't make sense. And I could see that to a large degree, everybody was kind of stepping back from it, going, yeah, I'm not going there. And it was just going to fall flat. So it was going to be legal, but no one was going to be able to access it because there were no assessors or providers. There were no protocols or medications available. So it just wasn't going to work unless somebody kind of took the bull by the horns and just did everything that they could to try to make it go properly. So that's what I did. I undertook to try to do whatever needed doing, from, figuring out what medications and how to source them, to trying to get provincial policies, to try to establish billing codes, the whole bit, right? So that's how I kind of got drawn into it.
Absolutely. It's an exceptional amount of work from both of your parts. All right. Thank you for that. For our next question, audience member asks, and maybe we'll start with Aaron first this time. What is the most difficult part of being a MAID provider?
Oh, that's a tricky one. I mean, there's a few things. The red tape is what can really leave a bad taste in people's mouths. I mean, not only do I do MAID provisions and assessments, but I also try to help train other MAID providers and try to troubleshoot and provide supports along the way. And I think a lot of people get cheesed off by the red tape that, government isn't facilitating. If anything, often government seems to be adding more red tape and more barriers in the way, in the name of covering their behind. So I think that that's a big frustration. One of the difficult things I see just in general is the coercion that patients experience to not have MAID. There's still a lot of parts, both within the system and just within the social structure, that pressure people not to consider this as an option. But I think lately, personally, the hardest thing I'm finding lately is the difficult track 2 patients, the ones that have not just a lot of physical disabilities, but have personality disorders, psychiatric issues, really complex social situations. and having to try to weed through all of those things, especially when they haven't really accessed healthcare. They haven't accessed the specialists. They can't get the expert opinion because they haven't gone through all that. So it's really hard when I'm used to being in a situation to try to help facilitate people, to try to help put them in touch with the resources that they need. When I have to kind of go the other direction and say, well, you really haven't done the workup, you haven't established these diagnoses. We can't really determine whether you're eligible or not for MAID on track 2 because we haven't done the work yet. You haven't had the investigations, you haven't seen the specialists. And it's hard to tell people no. It's easy for them to see me as being the one denying them, when in fact what I'm really trying hard to take the role of as being a facilitator, to sort of say, well, these are the things you need to do, these are the things you need to think about. If you're working an independent job and you're doing all your own, independent activities of daily living, it's hard to make an argument that you're in an advanced state of irreversible decline, but it's kind of subjective. So I think it's really when I can't give people what they're asking for, I find that difficult.
Absolutely. Thank you. And Erica, same question to you. What is the most difficult part of being a MAID provider?
So, as we said in my introduction, not only am I just a MAID assessor and provider, but I sit on the CAMMAP curriculum education committee. I co-lead, the topic 5. I do the provincial and territory advisory committees. I sit on clinician advisory council with Dying with Dignity. So I have all of these other roles, which I'll be true and say that most of this happens in my evening times. So, my day times are spent truly seeing patients, but there still are just not enough resources. We do not have enough MAID assessors and providers to cover. And I'm speaking broadly because I know it's in every province. And so we don't have enough MAID assessors and providers to cover our provincial territories. And so what's really heartbreaking to me is that when people will put in a request to our coordination center, and sadly they pass away before they get seen. And that's truly heartbreaking for me. I do echo what Aaron is saying around the track 2 folks and around, there not being enough resources from pain clinic perspectives, to get, folks seen in a very timely manner such that we can help alleviate their suffering. And so I think the hardest part of being a MAID provider is knowing that there needs to be 3 or 5 of me and there is not. And the other times when I have to say no because they simply do not meet criteria due to lack of resources.
Absolutely. Thank you for that. And there's a 2-part to this question, and Erica, will start with you again. And now we can ask this more upbeat question. What's the most rewarding part of being a MAID provider?
So I don't know what your audience will think of this, but for me, this is actually a privilege. I get invited into people's lives at the most intimate of times, the most vulnerable of times. And, so for me to come in and to, help to end your suffering, it's an incredible privilege. People will often say to me, I don't understand how you can do this day in and day out. But to me, this is not a job, right? This is a privilege because I hold it as a form of help when there's no other help to be had. And because of that, for me to be invited into those last moments of people's lives, it's absolutely incredible.
Yeah, absolutely. Beautifully said as well. Aaron, same question. What's the most rewarding part of being a MAID provider?
Yeah, I agree. I think that's to me it's almost a sort of a sacred undertaking, to come into the end time in somebody's life when so much is out of their control and there's so much suffering, and not just them, but everybody that they're connected to, their families, their friends, their community. And you take a situation that is desperate and you maybe allow them to have an option that makes it a little bit less desperate, that's a little bit more within their control. They can't control their illness and they often can't control a lot of other factors, but by going through this process, they can control where, when, and how they're going to exit. And whether they actually go through and have the provision or they just keep it as an option in their back pocket, then they have the choice. It's their call. And that makes a big difference to people sometimes. It allows them to be a little bit less afraid of suffering at the end, of losing who they are at the end. And that makes a big difference to people. And I think it also helps the families to see their loved one make that decision, to say, this is what I want, this is how I want to exit. And I think that really helps families to come to an acceptance of it, to reconcile the circumstances. And I think it's also really rewarding, kind of working as a team. You know, when this person is ill and suffering, and their whole family comes around them, their whole community, including their healthcare team, and the healthcare teams often go above and beyond consistently. You know, the nurse and the speech language pathologist and the person booking things and the secretary, and everybody kind of works together to try to do what can be done to help this person and this family. And when it happens, it really seems very special that everyone is kind of working together as a group. It really feels the way that the healthcare system should be. And so much of the time we're complaining it's not this way, it's not that way. But when it all comes together around a person, it's a very special time. And that's really quite rewarding.
Wonderful, wonderful. All right, thank you for that. For our next audience member question, what are the most common misconceptions that you hear about MAID? And Erica, we'll start with you this time.
So, you know, I'll be honest with you, I don't tend to misconceptions, right? My job is to get rid of those misconceptions when I see each patient or each family or both. Right. But I think some of the common things that I've heard is around what the eligibility criteria looks like, especially when it comes to dementia. Right. There are some misconceptions out there around that. And the other thing that I've heard several times, actually, which is a little disconcerting, is that MAID is painful. I'm not quite sure where that's coming from, because it's the total opposite. And so those are the two, I think, big misconceptions that I'm hearing.
Mm-hmm. Absolutely. And before we move on to Aaron, maybe we can just tackle that misconception about dementia specifically. Can someone with a dementia diagnosis even access MAID?
They absolutely can, right? The idea, though, is that in order to qualify for a medically assisted death, one of the eligibility criteria is that you must be capable of making your own decisions. So people who have been diagnosed with mild neurocognitive disorders, whether it be dementia or Alzheimer's or Lewy body, whatever type of disease it is, these people can still access MAID. It's just that we have to get to them, get their assessments done, know their wishes ahead of time, because people must remain competent in order to qualify for a medically assisted death. If
Wonderful.
someone asks for a medically assisted death who has progressed down that dementia track or that neurocognitive disorder track a little too far, then perhaps the answer is no, right? If they do not have the capability to make their own competent decisions and have insight and judgment into their request for a medically assisted death.
Thank you for that, Erica. And Aaron, just same question. What are most common misconceptions you hear about MAID?
Well, I agree with it's largely around eligibility. A lot of people don't even know that it's actually legal to have MAID. A lot of physicians I found who are kind of new to the subject matter are really not as aware of what the criteria are either, and are telling people that they don't meet the criteria. Oh, you're not eligible. When in fact they very well may be eligible. But by saying, oh, you're not eligible, it kind of gets it off of their responsibility. Oh, no, we don't even need to have the conversation. You're just not eligible for it. So I found I've had to do a fair bit of education amongst in hospital personnel, particularly internists and surgeons who aren't aware that things have changed, or that there's such a thing as track 2 or anything like that. And then sometimes we get patients who think that they can have it for any reason at any time, and that we have unlimited resources to be able to just do what they want whenever they want. So that's the other side of the coin, that sometimes patients think that they can just have it right away, and that they don't have to have an assessment process, or get a letter of expert opinion from somebody. So that's a little bit difficult to deal with when somebody thinks that I'm the one that is denying them, when in fact these rules were established by huge groups of people, and I'm just trying to apply them as best I can.
Sounds very much like your previous answer about that struggle of trying to re-represent yourself as a facilitator as opposed to a gatekeeper. Yeah, absolutely. Thank you that. All right, next audience question. This audience member asks, and we'll start with Aaron this time, when and if the time comes that I want to request MAID, who would be the first person I could contact? What are some of the basic steps in the process to even get started?
So there's a couple of ways that can happen, but probably the single best resource is your primary care provider. So whether that's a nurse practitioner or a family doctor, but just talk with whoever your main healthcare practitioner is about it, and educate yourself about what the criteria are, about what the resources are in your neck of the woods. I think most areas have a MAID coordination number that you can call that'll try to put you in touch. I know in Newfoundland, the 4 regional health authority areas each have their own coordinators, who can then try to find MAID assessors in your area and to get that started. Some people don't even know about MAID and want to find out more about it before they make up their mind whether they want to have MAID or not. So there's a lot of online resources, frequently asked questions. I know if you just Google MAID NL, you'll get the one for our province. Dying with Dignity has a lot of information. The federal government has some information, although it's a little bit cumbersome to wade through. And the Canadian Association of MAID Assessors and Providers has a lot of good online resources as well. So the coordination office, your primary care practitioner, or your specialist if you're dealing with a neurologist or an oncologist, and then online, there's a lot of stuff. That's what
Wonderful. Thank you. Erica, I just wanted to check if there's anything you had to add or contribute.
I would just add a wee little bit, which is if you have transferred provinces, it's always ideal to bring your medical records with you. Because if you are asking for MAID in Nova Scotia and you've come from Ontario, we would love to have your records ahead of time, right? Because we don't have the resources to go looking for them. We are going to hand it back to you. So anyone who's transferring between provinces, I would just advocate for you getting your own health records before you transfer.
Wonderful. Thank you for that. All right, next question, and we'll start with Erica this time. And this kind of leads into something we talked about with primary care providers and not necessarily having all of the facts on MAID. So this audience member asks, do you have any tips for talking to my family doctor about MAID? I don't know if they're supportive or not, or if they have all of the answers when I visit.
And you may never know, right? Because we don't know what anyone else is thinking. But what I would advocate for is that you have a very open, honest, truthful conversation. The bottom line is that no matter who you're talking with if it's your nurse practitioner or your family physician or your internist or your oncologist, if the person themselves, your healthcare provider, does not believe in MAID, it really doesn't matter. They have an obligation to make an effective referral to someone who does. And I'm saying effective because it's not just enough to say, oh yeah, sure, I'll send you to whomever. No, that doesn't work. Right? If we as healthcare providers do not make an effective referral, we can actually be reported to the college for that. So you can approach anyone that you wish about MAID. If you find that you're not getting the answers, keep looking. But it is on each one of us as healthcare providers to make sure that you do get the information and that you are provided with links so that you are able to ask your questions to the appropriate person.
Thank you. And Aaron, anything further to add?
Well, I think that most of the provincial colleges, physicians and surgeons have in their standard of practice around MAID that the patient, if they ask about MAID, that the physician has an obligation to have that conversation with them, or at the very least, put them in touch with somebody who can have that conversation with them. And it's a little bit trickier when you look at the College of Nursing, because I think they still stipulate, at least in most provinces, that the nurses and nurse practitioners aren't allowed to bring up the subject of MAID unless the patient has asked for it first. Has that changed, Erica? Good, I'm
Yes,
glad to hear
very
it.
much so.
I don't think it's changed here in Newfoundland yet.
So can I butt in?
By all means.
Yeah, so any nurse practitioner across this whole country is more than able to bring up MAID with patients. If we listen to the Canadian Nursing Association, which is again federal, any nurse should be able to bring up MAID. Because if a patient doesn't know their options for care, how can they make an informed decision? So the CNA says, absolutely, nursing, go ahead. It's our individual provincial and territorial colleges that are putting the brakes on this for RNs. No breaks for NPs, right? We as NPs bring it up whenever we think it's appropriate or whenever the person asks. Nursing, we're still working on, but the CNA is behind the nurses. So bottom line is nursing can do it. We just have to get behind their provincial college bodies. Sorry, I butted in there.
No, that's great. That's great to hear that that's changing, because I've been advocating that for many years, but unfortunately, I think the nurses' college doesn't like to listen to physicians too much.
Well,
So,
it sounds like progress has been made,
yeah,
but still lots of work to go. So that's good to hear. All right, thank you for that. For next question, and we'll start with Aaron this time. This audience member asks, can I apply for medical assistance in dying before I become critically ill?
well, I guess technically you can apply at any time, but you're really not going to be approved for it unless you meet all the criteria. So you have to be in an advanced state of irreversible decline. You have to, be aware of all your options for treatment. And so you really can't do it before you get the diagnoses and before you've been down that journey. It's usually for people who have tried all the options and are suffering intolerably, and there's nothing else that they can really do that will help their situation. And so unless you've reached that point where you're really at the end of the rope, then probably it's not really useful to apply preemptively. We have a lot of people who try to sort of apply right at the beginning of their diagnoses, and it's kind of a waste in some ways, because you won't be eligible right off the bat. You need to be down the road, you need to be along the journey. And so doing it kind of preemptively before you get there just really doesn't make good use of your time. But certainly you can have the conversations. That's sort of my take on it.
Thank you for that. And Erica, anything else before we move on?
Yeah, I do. And so I agree with Aaron, right? We can't be jumping the gun, because you do have to meet eligibility criteria. But the other thing that I would say is we can't wait too long, because if your trajectory is such that, you have a potential death within weeks, there is, I don't think, any possible way, but given the resources, that you're going to have 2 eligibility assessments and meet criteria and get everything in to place for a medically assisted death. So while we can't go too early, we cannot leave this too late either, because it just won't be an option.
Agreed. I know a lot of places when MAID, in Newfoundland anyway, a lot of the regions that haven't had MAID cases before, and people aren't quite as familiar with the criteria. Often the first few times we get a MAID request, it's often kind of right towards the end. And sometimes it's too far along to get things in place before the patient dies of their underlying disease. So it's really kind of too bad when we miss the boat that way. Now, sometimes there's nothing you can do. People are going along slowly, and then all of a sudden they crash. You can't preempt everything, but I think there's some of those cases. If we had the infrastructure in place a little bit better, people could have had the outcomes that they had wished to have. And that's really what I try to do better on when we come across those cases. We need to do better when we find those and improve upon that.
Absolutely. Thank you. All right. I've just noticed here we are getting so many questions from our audience. So in the interest of time, we'll just ask one speaker to answer. But of course, if there's anything vital, please feel free to jump in. We'll go with Erica this time. This audience member asks, does medical assistance in dying impact my ability to become an organ and tissue donor?
So the short answer is yes, and the short answer is no. Because it depends really upon the reason that you're having a medically assisted death for. So for example, if you are having a medically assisted death because you have a metastatic cancer, your organ donation status is completed because we do not take organs from cancer donors. Could you possibly donate corneas? We're on the fence with that. Most provinces will say no. However, if you were a quadriplegic who has suffered for many, many years and is now wanting to have a medically assisted death, absolutely, we may possibly take your organs dependent upon your age. What will impact, though, is that you will have to pass away in hospital. You will have to pass away very close to an operating room such that the organ donation recipient team can take your organs in a very timely fashion. So being at home, I mean, you can still be surrounded by loved ones, but being at home is likely not an option. So again, it's really around the reason why you're having MAID and the location that you're having MAID.
Wonderful. Thank you for that. All right, for next question, I'll go ahead and pose this to Aaron. Our audience member asks, I've heard before in the news that if someone doesn't have adequate social supports, they can receive MAID instead. Is this true?
I guess the short answer there is no. It's really, an underlying medical diagnosis. Now, sometimes the social circumstances do contribute to a person's suffering. So you have to look at the whole context. I mean, we have like complex cases where there's physical diagnoses and psychiatric diagnoses and cluster B personality disorders and social circumstances all together. And so you have to address all of those things separately. But if you are perfectly healthy and you have no underlying medical conditions, and you just have poor social circumstances, I don't think that you would qualify for MAID under my understanding of the legislation.
Wonderful. Thank you. Next question, I'll pose this to Erica. This audience member asks, if I'm diagnosed with a life-threatening illness, do I need to accept treatment options before I can become eligible for MAID?
The short answer is no. Of course, if there are reasonable treatment options that may help with your quality of life, we as MAID assessors may question why you wouldn't proceed ahead. But what we have to remember, right, is that sometimes our best treatment options are 4, 5, 6 hours away, right, from our hometowns. And so given that, are you able to travel to these areas to get what we would call, this acceptable treatment? So really, it becomes a conversation with the assessors and the patients and families to figure out what is actually accessible treatment, what is optional treatment, and what the end of life goals look like.
Wonderful. Thank you. For our next question, I'll pose this to Aaron. This audience member asks, how do you measure intolerable suffering? Is that something determined by the clinicians only, or is it a discussion with the requester?
To me, it's really completely to do with the person requesting. If they say that they have intolerable suffering, then I don't question that. I have had some instances where you say, you ask if somebody is suffering and they go, oh no, I'm not suffering. But then they can tell you quite articulately, why they want to end their life and why they were considering, driving their wheelchair off of their balcony the day before. and how they don't like the circumstances that their physical disabilities are causing them, that they're progressive brain tumor and the whole works of it. But to them, suffering, it means if your arm was hauled off by a truck or something like that, that would be suffering. But the circumstances that they're under are intolerable for them. So I think if they can articulate that, whether they say the word suffering or not, it's the meaning behind the word that is really what's important.
Thank you. All right, next question. We'll assign this one to Erica. This audience member asks, can I sign my power of attorney, or it might be substitute decision maker or agent in your province, to request MAID on my behalf in the future?
The answer is no, absolutely not. Right now, in order to qualify for a medically assisted death, you must meet criteria. We cannot judge on what your criteria may be in the future. So we cannot say, oh, if you develop dementia in the future, or if you develop a stroke in the future, you would want this. That truly right now is considered an advance directive. MAID is not legal for an advance directive right now. It will be coming, I'm sure. We're probably maybe 3 to 5 years away from it. Maybe sooner. I can't be 100% sure. We are working, but right now the short answer is no.
Understood. Thank you for that. All right. So our next set of questions are more related to provision-based, and we'll start with Aaron this time. This audience member asks, and this is more a broad question, for those who don't know, what are some of the responsibilities of a MAID provider, and is it fundamentally different from a MAID assessor?
Well, as a provider, you're usually the primary assessor. And so you do the assessment and then you do some other stuff. As a secondary assessor, you just do the assessment basically as a double check that the person meets the criteria. But as the primary, you're responsible for basically putting together all of the logistics of it, the where, when, how, ordering the medications, filling out the death certificate, filling out the federal reporting, keeping track of the records, making sure the records get stored afterwards. So and the medical legal risk of the procedure as well. So there's a bit more to being a provider. But as an assessor, as a secondary, you do the same assessment as the primary would do.
Wonderful. And again, just want to check in, Erica, if there's anything else you wanted to contribute here.
No, I'm good. Thanks.
All right. For our next question, Erica will ask, this audience member asks, what takes place on the day MAID is provided? Maybe just if you could provide a bit of an actual process of what it looks like.
Okay, so I'm taking the next half an hour. We can ask no other questions. No, just kidding. So basically on the day of MAID, I come to wherever the person and families are. The first thing I do is I say, are you sure? And that's getting that final consent, right? Because we always have to ensure that the patient can give us final consent. If the patient cannot give final consent, we have to ensure that a waiver of final consent has been completed. So it will either be gathering that final consent or making sure that the person who's been deemed as the substitute decision maker is allowing me to go ahead and continue with the medically assisted death. I will go ahead and insert 2 IVs at that point in time. Then I give people as much time as they need to say goodbye. That may look like 2 minutes, 10 minutes, 20 minutes, 2 hours. I've done MAID where the person was ready right away. I've also done MAID where we had a complete church service and it was an hour before we actually started our MAID protocols. So really, I give all of that time for whatever it is that the person is needing. Once they're ready, then the first medication that we give puts people to sleep. Most people are asleep in underneath a minute. That's all usually the person feels. That's all anyone in the room will see. The next medication is some lidocaine, which simply numbs up the inside of the vessel, because our third medication, which puts people into a coma, may sting a little bit. The last medication we give them once people are deep in coma actually stops their breathing, which then in turn stops their heart. From start to finish, we're usually looking at about 5 to 10 minutes. If it's a younger person with a very strong, robust heart, we may be a little bit longer. But that's really about it. So the families or friends will see a bunch of syringes going back and forth. The person that they're there with will fall asleep. They may lose their color. And then whoever is the provider will then pronounce death. And then I usually step out and I give family and friends as much time as they need. before I go back inside.
Wonderful. Thank you for sharing that. All
Mhm.
right. So for our next question, and I'll pose this to Aaron, this audience member asks, in your experience, are MAID requesters more often accompanied by their loved ones, or are they alone during their provision?
I think it's the full gamut. It's the same as end of life in non-MAID situations. Most of the time, I'd say people have their friends and family nearby. Sometimes they'll have their friends and family beforehand in the room. They'll say their goodbyes, and then people will step outside the room. We've had one or two where people just didn't have anybody to come with them, and so it was just the nurses and physicians and who were there with them at the end.
Thank you for that. All right, next question, and I'll pose this to Erica. This audience member asks, can I request my MAID provision take place anywhere?
Short answer, no. It must be private, right? Like I will absolutely do MAID on a beach, but I won't do it on a public beach. I will do MAID like in a park-like setting, but I won't do it in a public park, right? I will do a lot of MAID on back decks and verandas, but I won't do it with a bunch of people looking over that veranda, right? So for me, I will do MAID pretty much anywhere as long as it's within reason and private. And the other thing is that we have to always be cognizant of where our funeral homes or our university programs can actually come to collect the bodies at. We can't be somewhere where they have to climb down over a steep hill with their stretchers kind of thing. So there's those logistic parts that we have to think about, but I'm pretty flexible about where I do MAID. It's just, again, it's got to be private.
Understood. Thank you. All right, next question, and I'll pose this to Aaron. This audience member asks, what do you do in the event that a patient's veins are not suitable for an IV MAID provision?
We've never yet had a case that I'm aware of in the province where we haven't been able to gain IV access. But we have trained up a number of our providers to be able to insert an intraosseous trocar. So if you couldn't get an IV access, you could put an IO in, an intraosseous, which is basically like a big metal IV that goes right into the marrow of one of the bones. The other option would be the oral protocol, I suppose, where people can ingest some medications that will have the same effect, although that's much less common. I think less than 5% of cases are done with an oral protocol. And we've not yet had to use an intraosseous, although we could if need be.
Wonderful.
If I can quick.
Yes, absolutely. Yeah, I was just about to prompt.
Yeah, some of the times if I know that someone has really been very poorly with eating and drinking for some time before they requested MAID, sometimes I will ask the VON to go in and do a subcutaneous injection of some saline. So I give them about 500 mils, so like a small or medium-sized bag of fluid to try and pump up their veins again a little bit before I get there. There are some other options dependent upon the location. Working out in rural, it certainly doesn't happen as much, but sometimes if we know people are going to be a really big challenge, we can actually transport them to hospital for a PICC line prior to the IV insertion or prior to the MAID provision. It doesn't happen often because resources are not that fruitful. And so oftentimes I'll give just a sub-Q 500 cc's of fluid, like a day, maybe even 2 days, right? A day, like 2 days in a row before I know the MAID is going to happen. Yeah.
Thank you for that. And this time we'll pose the question to Erica. This audience member asks, so assuming that I've completed all the steps and have been found eligible for MAID, could I ask for a different clinician to give me my provision if I'm uncomfortable? And they give the example of requesting a female clinician for a female requester, for example.
The short answer to that is no. One of your assessors must be your provider. All right, so if you've only had 2 assessments, one of those assessors must be your provider. If you are uncomfortable with both of those assessors, then you can ask for a third assessment, and then that person could potentially be your provider, but you cannot have a provider that has not assessed you.
Wonderful. Thank you. All right, for our next set of questions, these are more related to the upcoming changes to the assisted dying program in Canada, specifically on MDSUMC. So we'll pose this first question to Aaron. This audience member asks, so after March 17th of next year, the expiry of the sunset clause, how likely is it that someone with a mental disorder will be found eligible for MAID?
Oh, it's very likely. In fact, I'd say it's almost certain that somebody will. I mean, we already have patients who have mental disorders but have other medical conditions who are qualifying for MAID. We just have to track down, that they've had their mental illness addressed, and that they've had somebody determine that it's not affecting their capacity to make rational decisions. But we certainly have had patients who've had mental disorders who make their own decisions about having MAID, just as people with mental disorders make their own medical decisions about lots of other things, about having operations or whether they want a certain treatment or not. So just because you have a mental disorder doesn't mean you've lost capacity, but sometimes it's in question. And in that case, you need to have psychiatry involvement, or somebody who really knows the patient, like their family doc, who's been involved with their treatment. But in terms of MD-SUMC, where mental disorder is the sole underlying medical condition, yeah, we've got patients already who are just waiting for that sunset clause to expire, who are like the next day they're going to have that requested.
Absolutely. Just wanted to check if there's anything you wanted to add or contribute.
No, I totally agree with what Aaron said. The thing is that I think each province is going to roll out how they do MD-SUMAC. I'm not going to say differently because we all have to follow that federal legislation. However, I do know that in Nova Scotia, we are going to absolutely require that at least one of the assessors will be a psychiatrist for MD-SUMAC. And then the second assessor will actually have to be vetted by the first psychiatrist to make sure that they're actually eligible to make the decisions. So we have some pretty robust criteria that we're going to be rolling out here in Nova Scotia. I most recently read quite a few studies around MD-SUMAC over in Europe, Belgium, Netherlands, those types of areas. And, they've been doing MAID for mental illness for quite some time. And the actual population that requests MAID is quite small. And then the percentage of population that actually proceed on to a medically death is incredibly small. And so while we are gearing up here in Canada for, I think, a lot of people to initially flood the system, I don't know that it's going to be a huge draw going forward, but I think that in the beginning, there's going to be a lot of folks who are going to want to be reassessed or assessed and then see where they go from there.
All right, thank you for that. All right, we'll pose this question to you, Erica. Our audience member asks, do you have a sense of what types of conditions or medical history could qualify someone for MAID come March 2024?
Yeah, so I mean, there are a bunch of mental conditions, of course, as we know, but when we think about someone who's been chronically and majorly depressed for quite some time, a generalized anxiety that's lasted for a long, long time, maybe schizophrenia, bipolar, borderline personality disorders, even some somatic disorders, eating disorders. We may find that all of those will be on the list. It really just depends on if you meet the criteria around being eligible for a medically assisted death. And so what that will look like is, is that grievous and irremediable? So is this condition something that causes absolute grief? Being irremediable, meaning we can't change it. Have we done everything? Have we tried everything in order to change it? Is the person in a state of decline? So are they suffering? So we still have to meet those same guidelines that, C14 and C7 set out. It's just now going to be proposed onto a mental health as the underlying condition, not a pancreatic cancer or an end-stage organ failure.
Thank you for that. And just want to check, Aaron, if there's anything you had to contribute.
I agree. That was well said.
All right, I agree. All right, next question, and I'll pose this to Aaron. This audience member asks, how might a MAID provider consider whether a requester has considered all treatment options in the event that the care that they could have received has been otherwise unavailable?
Well, I think we have, an obligation, if you're the assessor, to have a certain awareness of not only the patient's medical journey, but also what other types of things might be available. So, sometimes when we come across a request from something that we might not be as familiar with, then we have to do our research. We have to talk to people who know about the treatment of these things. And in some cases, there are no specialists, like in the case of myalgic encephalomalacia, or what we used to call chronic fatigue syndrome. I mean, there's no one who has a declared college specialty in chronic fatigue syndrome, but you can network throughout the country, and you can find people who have done extra studying on it and who've treated patients on it. So people who in effect are experts in it. I think you just have to do your due diligence.
Absolutely. All right, we've got some more audience questions here. We're going to try to get to as many as possible with the time permitted. Let's go ahead and start with Erica this time. This audience member asks, you previously mentioned dementia. Would you need to be at a certain stage of dementia to become eligible for MAID? If someone has a dementia diagnosis, when should they start preparing or make that request for medical assistance in dying?
Right. And so remember, right, you still must meet eligibility criteria. And so in that eligibility, sorry, I can't talk. In that eligibility criteria, it outlines the fact that you must be in a state of irreversible decline and you must be suffering. And so, if you're able to still, write out your grocery note, get in your car, go get your groceries, and then come back and pay for that on your bank account kind of thing, then you're not quite yet there, despite the fact that you may have mild dementia. And so oftentimes what I will do is, if someone is consulted soon and early to the dementia team or to the MAID team, I may go out and see them and I don't say no, but I say not yet. Right. And so then I kind of, and as a full-time MAID assessment provider, I have the luxury of doing this, which is I then develop a relationship with that person where maybe I'll see them every 6 months. Right. I have that luxury, whereas there are many, many providers that do not have that luxury. So early in the stages, just be cautious that you meet criteria, but again, not leaving it too late. And really is that up to the actual person to decide? No, it's not, right? It's up to the assessor and provider to decide if you meet the criteria. So I would say just keep asking.
Thank you for that. All right, next question, and we'll pose this to Aaron. This audience member asks, does having MAID affect my life insurance?
No, it doesn't affect your life insurance. Initially, that was a bit of a concern. But in fact, it turns out even if somebody ends their own life, not with MAID, but with what we would, I guess, traditionally call suicide, usually it doesn't affect your life insurance unless it's a very recent purchase of a life insurance. But if you've had life insurance for more than 6 months or a year, then if you take your own life, that doesn't affect your insurance either.
All right, thank you for that. Next question, and I'll pose this to Erica. So it was kind of mentioned throughout the session, but I think this audience member is looking for some clarification. They ask, what is track 2? And as a follow-up, is someone with dementia considered a track 1 patient or a track 2 patient?
Great question. So track 2 patients are what happened when the law changed in March of 2021. Prior to that, you had to have what was considered a reasonably foreseeable death. So that would be someone, of course, with end stage heart failure, COPD, metastatic cancer. In March of 2021, the law changed to deem what was called not reasonably foreseeable death. And we've kind of put these people on what we would call a track 2. So these are folks who do not have a reasonably foreseeable death, but still at the same time meet eligibility criteria around grievous and irremediable condition, around irreversible decline, and around suffering. When we think about dementia, when we feel, I can only speak personally. When I feel that someone is absolutely eligible for a medically assisted death based on their dementia diagnosis, I think there are multiple things that can happen that absolutely make them track one. So I tend to put my dementia patients on track one, meaning that we can do a waiver of final consent such that they should lose their ability to choose for themselves.
Wonderful. Thank you. All right, next question. I'll pose this to Aaron. This audience member asks, after I've completed both of my assessments, do I need to have MAID right away?
No, you can delay indefinitely. The legislation doesn't stipulate any time frame that you have to stay within. Although I think most MAID assessors would say if it's been more than 3 or 6 months, then you have to sort of reassess the situation. In some places they say you have to reapply and submit the paperwork again, but I think most places see that as just a duplication of paperwork. So we would sort of put things on hold and then reassess when the patient wants to go ahead with things. You can delay as many times as you want. You can change your mind right up to the point of just before we give the injection. So it's really about the patient's decision when and where and how.
Thank you. This question is for Erica, just because you touched on it in your previous answer. This audience member would like you to please explain the waiver of final consent and why it's used.
So a waiver of final consent is where a person who's requesting MAID still has capability, right? So I have to put that out there first. So the person must be capable of making decisions. And so when they do that, then they can appoint what's called a substitute decision maker to act on their behalf should they not be able to. So basically that waiver of final consent is where we as the provider will waive the final consent from the person, but look to the substitute decision maker to make the decision to go ahead with MAID on the person's behalf. I often say to people, be very cautious around who you choose as your substitute decision maker, because that person must be able to tell me that it's okay to end your life. And my husband will say, Erica, don't choose me as your substitute decision maker. I don't think I can do it. Right. So I will say to folks, be very cautious. It doesn't have to be your spouse. It doesn't have to be your child. It can be whomever that you trust to make the decisions on your behalf. Now, with that waiver of final consent, right now, it's federally legislated that we must choose a date for MAID on that form. I have my own choice words around what that policy looks like. But, I say to folks, if you're not quite ready and we don't quite know, we pick a date, perhaps maybe 3 months in the future to get your affairs in order. And then that allows your substitute decision maker to act on your behalf for the next 3 months. If we're coming up to the date on that form and you're still not ready for a medically assisted death, but you still qualify, then we can always put a new waiver into place, again, appointing either the same or a different substitute decision maker and just changing the date of your MAID to move forward.
Thank you for that. Next question, and I'll pose this to Aaron. Can you speak to the Canadian Association of MAID Assessors or Providers, or CAMAP? Can you speak to the new curriculum work that was recently released?
Oh yeah, they've just spent a fair bit of time and effort from people all across the country to put together a wonderful new curriculum for training, not just on basic assessment and provision, determining capacity, but also with complex cases, how to navigate through really tangly situations. And they have one coming out on doing an assessment for a patient who's requesting who has a psychiatric diagnosis. So I think it's a really wonderful opportunity to learn and to learn in depth from some of the most experienced assessors and providers in the country. Unfortunately, we haven't been able to get any of the curriculum going here in this part of the world, in Newfoundland anyway yet. Maybe Erica, you can come down soon and we can have a session.
Absolutely, I would. What I would also say to that is that right now it's only topic 1. that's open to the general public. The other topics right now are held tight for physicians and nurse practitioners. Even allied health professionals cannot access those other module or topics right now. So yeah, but that will change.
All right, thank you. All right, for next question, I'll pose this to Erica. This audience member asks, what would you say about how to encourage, those that work in the MAID space, palliative care, and hospice care to coexist in a way that's supportive of each other?
That's a really, really nice question as well. And, across this country, we all vary. There, especially in the beginning of MAID, there was some, tug and pull around whose domain this was. When in actuality, we actually share this domain because we as MAID providers, we don't want to go in and end your life before the time is necessary. And so excellent palliative care, excellent hospice care can give you that extra time before you're looking for your MAID provider to come. And so, my stance has always been an open, honest approach, looking at each role being incredibly, incredibly important, and not one of us trying to outdo the other.
Wonderful. Thank you. All right, next question. I'll pose this to Aaron. This audience member asks, what is the percentage of MAID requests versus the actual approved requesters?
It's different year by year and region by region. Out in Newfoundland this past year, the number of MAID requesters, less than half of the people who actually requested and were found eligible actually went ahead to have MAID. I think nationally it's somewhere around 60-70%, depending on the year, of people who request actually end up having MAID, but certainly not everybody.
Yeah.
Thank you for that.
In Nova Scotia, we had 68% last year follow through.
Wonderful. I was just about to touch on that, Erica, so thank you. All right, for next question, we'll pose this to Erica. And you touched on this before. Audience member just wants to ask once more. How long is the actual MAID provision? What does that normally kind of take?
And so it's really different, right? Because everyone is different. Sometimes I walk into people's homes and they're like, oh, hey, she's here, let's go. And we get started and maybe I'm in and out of the home in 30 minutes, sometimes maybe even 20. That's not often because I tend to talk. but I mean, sometimes it's 30 minutes, sometimes it's an hour. I will say that I always allot, if I can, and I do, about 90 minutes, right? Because I like to make sure that we don't rush through things. I like to know who's in the room with us. I like to acknowledge people. And then once the MAID is completed, I don't tend to run away, right? Because I tend to make sure we've got our funeral home arrangements done and someone or me has called. I tend to make sure that everyone is as okay as they can be before I go. There are sometimes I sit for tea. It really depends upon, what each patient and family are looking for. Sometimes people just don't want to see me thereafter and I make a quick exit, right? So it's really dependent upon. So I would say generally, I mean, it's anywhere from 30 to 90 minutes.
All right, thank you for that. Next question, I'll pose this to Aaron. Audience member asks, does the requester's family have to be aware of their request for MAID and, quote, on board with it?
No, it's an individual choice. Usually we encourage patients to try to include their family in some way. But in the end, it's their call. Sometimes if they have a family who they know is very much against their having MAID, they just don't want to go through the grief of having that fight and that push and pull. And they just no, just tell them after the fact. In those cases, I try to encourage the patient to write their family some letters. Because it's awfully hard on a family when they don't know what's coming. They can't prepare themselves emotionally, and it's much harder for them to accept, much more likely that they're going to end up with complex grief, and that's something that can stick with people the rest of their lives. Why did they do that? Why couldn't they tell me? So I think it's really it's hard on the family members when they don't get informed, but in the end, it's the patient's choice, and that's it.
Thank you for that. Next question, and I'll ask Erica this one. Audience member asks, what is written as the cause of death when someone receives medical assistance in dying?
So this varies between provinces and territories. Federally, there is no rule. So each province and territory gets to decide what goes on their death certificate. We're right now split across this country about 50-50, with those who just will put the cause of death as whatever the cause is. So if someone passes away with MAID because of a pancreatic cancer, then the cause of death is pancreatic cancer. In the other half of the province, we actually have to put on the death certificate that the patient had a medically assisted death. So here in Nova Scotia, we actually have to put injection of propofol and rocuronium, which is our actual two medications that cause the MAID death. Underneath that, then we state the cause, pancreatic cancer. I will tell you that I'm a big champion and proponent of not having it on a death certificate. All of us as MAID providers have to report federally each case. I see no reason to have this. We don't keep statistics in our province. And so I am a champion to get this off the death certificate because I don't believe it belongs there. So I'm still fighting, but right now the country is split between what we're doing. So it's really provincial jurisdiction.
Thank you for that. Next question, and I'll pose this to Aaron. Audience member asks, what has been your experience in situations where a requester has asked for spiritual care or guidance during their provision?
I find most of the time we can access some spiritual care providers. We've had some instances where the person designated on hand, was very much against MAID and refused to be part of it. But that's usually the exception. I'd say, 80-90% of the time, even if they may not agree with MAID themselves, they're willing to journey with the patient and be there as a support for them. So I'd say most of the time it's not hard to access, but occasionally we can't get it to happen in time.
All right. Thank you for that. We just have a few more minutes here, so I'll try and narrow down these questions. Thank you so much to our audience. Next question, and I'll pose this to Erica. Audience member asks, have you ever worked with death doulas? And if so, can you describe that relationship?
So here in Nova Scotia, that is not a common entity. But I have had the fortunate opportunity to actually work with one death doula. And she was actually there during the MAID assessment. This person has not journeyed on to have a provision yet. But when we do, she will be there as well. And so basically that death doula acted as an advocate on behalf of the patient. I mean, she didn't really have to do much, in all honesty, because I was there for the patient who obviously qualified. But I think any extra support system whatsoever that the patient can access, go for it, right? Always a plus, as long as the patient is supported.
All right, thank you for that. And we'll pose this question to Aaron. Audience member asks, what is the difference between using a waiver of final consent and an advance request for MAID?
Well, a waiver of final consent, I guess, is sort of after you've had the assessment done, you're eligible and you're at risk of losing capacity. That's when you would set the waiver of final consent, which is stipulated fairly rigidly in legislation. You have to pick a date, you have to both sign it. And whereas an advanced request will be more of a theoretical at some point in the future under circumstance A, B, C, or D. If that should come to pass, then I want to have an assisted death. And it's more of a theoretical kind of if, rather than it has already occurred and I might lose capacity. So that's the main difference. And the other difference, of course, is that a waiver is legal, whereas advanced consent is not. An advanced directive for MAID is not currently eligible. Although I think Quebec is in the midst of putting through some legislation that will possibly change that.
All right, thank you for that. Next question, I'll pose this to Erica. Audience member asks, is dementia considered a form of mental illness?
No.
All right, thank you for
Short
that.
and sweet.
Resounding.
No.
Yeah, short and sweet. No, perfect. Next question. Let's see here. Okay, I'll pose this to Aaron. Audience member asks, will MAID providers travel to rural communities for requesters that cannot travel to receive their provision?
Sometimes at their discretion. I think a lot of MAID providers go above and beyond, and I know many providers who have traveled, 2, 3, 4 hours one way, and then 2, 3, 4 hours back again afterwards, sometimes out of their own pocket, because nobody else would be there and the patient would be left in the lurch. Although that's not feasible for all people, and it's not feasible for anybody all the time. So there is, there are certain areas in rural Newfoundland where there are no providers, and it may take us, a week or two to get somebody from an adjacent area to go over there. Sometimes that's resulted in somebody missing the boat, and then they deteriorate too much and die or lose capacity before they could be assessed. So that's unfortunate, but that's also true in pretty well every other part of our medical care. People can't access, heart transplants or bypass operations in all areas either.
And for perspective, I usually put about 6,000 kilometers a month on my car.
Wow.
And I mean
Oh my
that, a
goodness.
month. That's how
Wow.
much
You get your
I travel.
mileage back?
I'm probably only home about 2 nights of the week.
Wow. Do you get your mileage back?
Kind of, sort
Wow.
of. It all depends on the price of fuel.
Wow. Well, thank you for both of your hard work in that respect and trying to go the extra mile, quite literally, for your patients. All right, we'll try and get 1 or 2 more questions in. I'll pose this to Erica. Audience member asks, if someone does not wish to exhaust their treatment options, can they still meet the eligibility criteria for MAID?
They absolutely can. Right. The thing is that, there is nothing that says you have to try every single thing, every single possibility that's out there. Sometimes people value their quality of life over their quantity. And sometimes what our treatment options are will give us quantity, but they don't give us quality. And so there is not a need to exhaust every single option. Now, when we talk about MD Sumac, again, we're not going to have to talk about every single option, but we are going to have to talk about very well-known treatment options that people potentially may have tried, right? Must have tried, right? It's going to be a little bit different when we talk about MD Sumac. It might be a little bit different when we talk about track 2 folks. But if we're talking about track 1s, where we're talking about the difference between quality and quantity, then no, you don't have to exhaust every, and I mean, I shouldn't say that, because even with track 2s and MD Sumac, we're not going to make you do absolutely every single possible thing that's in the literature. We just have to be reasonable about it.
All right, thank you for that. Unfortunately, we're out of we're out of time today, rather. Thank you so much to Erica and Aaron for joining us today. And I just wanted to highlight this lovely comment that somebody had submitted. Audience member says, just want to express my gratitude and respect for these 2 wonderful practitioners. So thank you so much for that wonderful note. All right, everyone, webinars like this one and all of our other compassionate services are provided free of charge to Canadians navigating end of life, their loved ones, and their healthcare providers. To enable us to continue providing these services, we ask that you please consider making a charitable donation, and we'll put the link in the chat for anybody that would like to consider donating. Thank you so much to our audience members today. Thank you for the multitude of questions. Love the enthusiasm, love the breakdown of all these questions. So again, thank you so much for engaging, and we wish you all a pleasant afternoon. And once again, thank you so much, Erica, Aaron, for joining us.
Thank you, Amanda.
Sure. It was my pleasure. Thanks for having me.
Wonderful. Everybody have a wonderful afternoon.
Cheers.